Hey, health warriors! Do you have patients who are breathless with minimal activity, complain of chest tightness, or have unexplained fatigue? They might be living with pulmonary hypertension, a progressive, often misunderstood condition that can lead to right heart failure if not caught early. Today we're breaking down what PH is, the different types, and how nurses can help manage symptoms and educate patients for better outcomes.
Pulmonary hypertension is defined as elevated pressure in the pulmonary arteries, often leading to increased workload on the right side of the heart. There are 5 groups of PH, classified by the World Health Organization based on their underlying cause. Group 1, pulmonary arterial hypertension, PAH, idiopathic, heritable, drug-induced, or associated with connective tissue diseases like SLE or scleroderma. Group 2, PH, due to left heart disease, includes systolic or diastolic heart failure and valvular disease. Group 3, PH, due to lung disease or hypoxia, COPD, interstitial lung disease, sleep apnea. Group 4, chronic thromboembolic PH, CTEPH, caused by chronic pulmonary embolia obstructing the arteries. Group 5, PH, with unclear multifactorial mechanisms, sarcoidosis, hematologic or metabolic disorders. Symptoms are often non-specific, always important. Dyspnea on exertion, fatigue and weakness, chest pain or pressure, palpitations or dizziness, syncope in advanced stages, peripheral edema and signs of right-sided heart failure. Diagnostic workup, echocardiogram, often the first clue, estimates pulmonary artery pressure. Right heart catheterization, gold standard for confirming diagnosis and measuring mean pulmonary artery pressure, which is 20 millimeters of mercury or higher. Pulmonary function tests, PFTs, assess underlying lung disease. VQ scan or CTA, rule out thromboembolic causes. BNP levels help assess right ventricular strain.
For patients in Group 1 with pulmonary arterial hypertension, the treatment options include endothelin receptor antagonists like bosentan, phosphodiesterase 5 inhibitors such as sildenafil prostacyclin analogs like epoprostenol and calcium channel blockers, but only in vasoreactive patients. For Groups 2 and 3, the focus is on treating the underlying heart or lung disease. Diuretics can help manage fluid overload, and oxygen therapy is essential if the patient is hypoxic. In Group 4, anticoagulation is crucial. Surgical intervention, such as pulmonary thromboendarterectomy, may be necessary, and for those with inoperable chronic thromboembolic pulmonary hypertension, the medication riociguat can be beneficial.
The role of the nurse in managing pulmonary hypertension is vital. Nurses must monitor for worsening dyspnea, oxygen desaturation, and signs of right heart failure. Administering medications and evaluating for side effects such as hypertension, flushing, and headaches is also key. Teaching patients is another critical aspect. Nurses should instruct on how and when to use oxygen, the importance of medication compliance, and the need to avoid high altitudes or strenuous exertion. Emotional support is particularly important for patients with Group 1 PAH, where the prognosis can be poor. Coordinating care with specialists in pulmonary, cardiology, and palliative care is often necessary to provide comprehensive care.
Pulmonary hypertension can quietly steal breath and stamina, but early recognition and strong nursing care can preserve quality of life. Have you managed a patient with PH? Share your insights in the comments. Like, subscribe, and follow for more cardiopulmonary care tips, delivered straight to your brain and your heart.